All right, so we'll start the review session. I'll go through the neonatal exam. I'll go through the advanced equipment exam, and then we'll go through the PFT reports, looking at the new tests we talked about, the MVV, diffusion capacity, and FRC. So to start with, for the neonatal exam, questions that a lot of people missed. Let's see. One of them was talking about the placenta. And it's true that the placenta is fed by 2 fetal arteries and 1 fetal vein. It does contain chorionic villi, that's the name of the blood vessels. It is not a good source to use when you're sampling fetal pH. If you're going to sample fetal pH, the placenta is not something that you would take a blood sample from. That's got mom's circulation and fetal circulation, so it would not represent the fetus. The next one is talking about fetal hemoglobin. It says if a normal P50 for an adult is 27 millimeters mercury, and remember when we talk about P50, that's when the blood gas machine figures out if the hemoglobin was only 50% saturated with oxygen, what would the PaO2 be? And then if it ends up that the number is higher, then the oxygen is letting go of the hemoglobin more readily. If the number is lower, the hemoglobin is holding on to oxygen more tightly. So fetal hemoglobin holds on to oxygen more tightly. That creates a shift in the curve to the left. And it means that the P50 would be a lower number than 27. I wonder if I graded question 14. Which of the following best describes fetal circulation? I'm going to write myself a note to go back in and check it, because one of them was blood from the inferior vena cava or superior vena cava enters the right atrium, flows to the right ventricle, exits into the pulmonary artery, and then bypasses the lung via the ductus arteriosus. Because it said superior vena cava, I guess it confused a lot of people. So I want to double check how everybody did on question 14. And blood enters the right atrium, it's shunted across the foraminal valve into the left atrium, travels to the left ventricle, and then is ejected into the aorta. So those were the 2 correct responses, and I'll double check on that.
But I thought that the inferior vena cava and the superior vena cava empty in the same location.
Like, yes, they do.
Yeah, that's what I thought. Okay.
Yeah. And then compressions and ventilations during CPR of a newborn. Giving a breath every 1.5 seconds equals 40 breaths per minute. So it's 120 compressions per minute and 1 breath every 1.5 seconds is the correct response. So many people missed this. I gave credit to everybody for that question. Oh, and then for APGAR score, I gave credit for that question. And then what to do depending on, oh no, this one you guys should know. And oh, everybody got it right. During the first minute of life, everything seems normal. What do? And you just observe. So that was, everybody got that correct. And question 23, I gave everybody credit for it because 6 people got it correct and 7 people got it incorrect. And we have a baby born at 26 weeks of gestation at 2,000 grams. She's requiring 40% oxygen because her SATs are low. She was limp and had labored breathing. Currently, she's 120 per minute. Respiratory effort has improved, but there's still some grunting. So if you've got a good respiratory effort, but you see grunting, the grunting, especially with a 26-week gestation, you think low surfactant, you think alveoli are collapsing, we need to give some surfactant and positive pressure. So if you selected nasal CPAP, intubate, give some Curasurf, that was correct. Or if you put mask CPAP, adjust FiO2, I marked that as correct also.
Okay, so the right answer for that was the Curasurf one?
Yes, from the
Oh, okay.
6-weeker.
All right.
Yeah, but I gave credit for both because
No,
we
I
haven't talked
understand.
about Curasurf yet. So maybe a lot of you didn't know what Curasurf is. So
Okay, I just figured because of the weight, you were implying that they needed surfactant. So because it's
oh, okay.
5 times 2. So
Yeah. And that's the proper way to think. Very good. What is the earliest gestational age you would expect a newborn to be viable and to have adequate gas exchange to survive? Meaning that if you need to give surfactant, it's okay. And 9 people selected 24 weeks, which is correct. And 4 people selected older gestational ages. So to be viable means to be able to support life. And it means, yes, us putting the baby on a ventilator, giving surfactant, you know, supporting them. And can they still live? Yes. But less than 24 weeks. I mean, now they're keeping some 22-week babies alive. But you don't have the development of the alveoli yet. You don't have the pulmonary capillaries developed enough. They're not close together enough to have air exchange going on between the alveolus and the blood. So that's why less than 24 weeks, we say it's not viable, meaning that it can't support life.
I can't remember if I answered that correctly or not, but I can definitely say that the wording on that kind of confused me because I know you were saying that at around 24 weeks that the type 1, type 2 cells are forming, but then you also have in your PowerPoint, it says 28 to 38 weeks surfactant is secreted into alveoli. So I wasn't really sure if you meant like, is the surfactant there already, or is it like you need to add surfactant to it? I think it was just the wording that messed me up on that. I don't even know if I got that one right or not, to tell you the truth, because I was tied between 28 and 24.
Yeah, it says with or without exogenous surfactant. So it mentions, okay, are they viable even if we give surfactant?
I think I'm having the big word moment where I couldn't understand the words. So sorry.
The big word moment? What was the big word?
The one you just said about surfactant.
Oh.
Yeah. Having a moment, sorry.
So exogenous just means that it's surfactant that we create outside the body and we deliver it to the body.
Okay.
Exogenous. Oh, okay. Okay, everybody got the shunts correct for fetal circulation? And that's it. So that was the neonatal exam. And now I'll go, and then do you have any questions on that or anything with neonates before I skip over to advanced equipment?
No. Did you get my email though?
No, I
I-
haven't checked emails yet.
I just wanted to come see you after the review. That's all.
Okay, are you on campus?
Yeah, I'm here.
Yeah. Okay,
Yeah. All right, I'll
Um,
come.
yeah, that'll work out.
All right, thank you.
You're welcome. All right, so then I'm trying to think lecture notes, like we talked about assessing a newborn with the APGAR score, with doing the Silverman-Anderson scoring for respiratory distress. And I think that's all we got to. So we can always discuss it next week if you want to look at your notes first. All right, everybody scored really well on the advanced equipment exam. What helped was there were 7 extra credit points. And everybody got all the extra credit correct. So that boosted up your grade. And then I went through the questions, and any questions that half the class was missing, I gave credit for those also. Yeah, you have a patient in bivent with an acidotic blood gas, low PaO2. 11 out of 13 answered it correctly. So what improves CO2 in bivent? Almost everybody got that correct. Here's a question. Modes of ventilation that would not help workup breathing if the patient's effort to breathe has caused an increase in their inspired tidal volume. So if their effort to breathe increases their tidal volume in PRVC, remember if the patient's moving the tidal volume and not much pressure is needed, the ventilator keeps lowering the amount of pressure during inspiration. So it could go from 20 down to 17, down to 14. If the patient's still taking deep breaths, it'll keep just going all the way down and deliver no pressure, no inspiratory pressure for the breath. So that can happen with PRVC and with volume support. Let's see what else is listed. Yeah, so it would be those 2 modes of ventilation that if the patient's breathing deep, it just keeps decreasing the amount of help during inspiration. So that's one of the negative aspects of using PRVC. And just to be aware of it, since if you're working in this area, most of your patients are going to be in PRVC. So if you see them working really hard to breathe, maybe they need to be switched over to pressure control. So at least they're guaranteed a minimum pressure during inspiration rather than having no help at all. So 5 people missed question 7, and it's asking about why is not much sedation given with bivent. So bivent APRV, you're counting on spontaneous breaths to get rid of some of the CO2. So when you're having these long pressure holds. It's actually like a long inspiration, 4 seconds, 5 seconds. That makes for a really slow respiratory rate. You only get an exhalation like once every 5 seconds. And it may not be enough to blow off all of the patient's CO2. So to compensate for that, if you let the patient breathe spontaneously while these two pressures are going on, it helps them to get rid of their carbon dioxide. So you would have selected at lighter sedation, so they breathe spontaneously. Everybody selected that. But then lighter sedation because spontaneous breaths are necessary to blow off CO2. So I gave everybody credit for that one. And then a patient's in volume support. They're getting 5 mLs per kilo with their tidal volume. Their PEEP is 5. You look at the peak pressure during the spontaneous breaths, it's 10 centimeters of water. What can you conclude? So remember, in volume support, the amount of pressure support is the delta P. So peak pressure minus PEEP is the amount of pressure support the patient is needing to move their tidal volume. So if you have a peak pressure of 10 and a PEEP of 5, 10 minus 5 means you have a delta P of 5. So that's how much pressure support is needed during this volume support breath. So 5 centimeters water pressure support. What can you conclude about only needing 5 of pressure support? Do you conclude that there's a leak? No. Can you conclude that the patient is ready to be weaned off the ventilator? Yes. So they're not requiring much pressure to move their tidal volume. That's a good thing. That means they've got good lung compliance, and they're able to move that volume in and out of their lungs with a minimal amount of pressure support. Does it mean that lung compliance is normal? Yes. Does it mean that minimal pressure support is needed to maintain the tidal volume? Yes. Hold on 1 second, guys. See if I can. So do you have any questions about that test question? No?
No, I'm good. Thank you.
Okay. So 10 out of 13 students selected correctly for the breath type that needs inspiratory cycle off and rise time to be set. So you're looking for any pressure type breaths. I don't know if I gave everybody credit for this one. I probably did. 5 people got this one correct, 8 people missed it. When you're in volume support, how much pressure support is being required to achieve the targeted tidal volume? Do you look at the high pressure limit? The answer is no, because alarm settings indicate nothing as far as pressures that are being used to ventilate the patient. The amount of pressure support will be peak pressure less PEEP. That's correct. Can you look at the pressure time graphic and look at the pressure that is being generated? Yeah, so that's the same thing as looking at your digital readout or versus looking at your graphic. I gave everyone credit for this. 7 selected the correct response, 6 people missed it. It's talking about alarms that occur in PRVC if the patient is breathing deep and fast and has a high minute volume. So you should get a high minute volume alarm and you should get a high respiratory rate alarm. you're not going to get a high pressure limit alarm. If they're breathing in really deep, you're not going to get a lot of pressure building if they're breathing in deep. But you could argue that, well, what if they start exhaling while the breath is still going in? So if they're breathing fast and deep, maybe they're asynchronous and maybe they're trying to exhale while the breath is going in. That can cause pressure to go up, even in PRVC. So I gave credit if you selected high pressure limit, but that's not what I was looking for in the answer. And then 8 people got this one correct, 5 people missed it. What causes a decrease in tidal volume in pressure control? Would high lung compliance cause a decrease in tidal volume? And the answer is no. High lung compliance means you have really easy to ventilate lungs. They're very stretchy. If you have low airway resistance, that means your airways are wide open. There's not much resistance to the air going in. You have a left main stem intubation, yes. So if you're only ventilating one lung compared to ventilating both lungs, you're going to have a smaller tidal volume. All right, this question shows a blood gas with a patient in PRVC, and the patient has a normal pH. Now, I know we've gone through this in the lab. If a patient has a normal pH and their CO2 is high, do we need to make vent changes to blow off the CO2 to get the CO2 into normal range?
No.
No. Only 5 out of 13 students selected the correct answer. And we went through this already, so I don't understand. And I'm sure you guys have this in your clinicals too. If you've got a patient with COPD, they've got a compensated blood gas. Are you still shooting for a CO2 of 40? No, you're not. Yeah, I know there's 2 of you here. Maybe the 2 of you can tell me what your thoughts are. Maybe be spokespersons for the class and tell me why so many people are missing this.
I know me personally, I think I got confused because of clinicals. Because I asked for help on ABGs because I like want to make sure I do good on my ABGs and I know how to read them. I think I got confused by when I was taking the exam. I was thinking about what one of the instructors said to me, and I'm not blaming them, but it confused me in the moment, and that's what happened. But when I was taking the exam, I knew the correct answer. I knew in my heart, no, you don't change anything. You leave it alone. That's good. That's a good pH. But I just got confused thinking about clinicals. So that's what happened to me.
So what did the clinic instructor tell you?
What was it? I can't remember. I just remember in that moment, that's what caused me to answer that way. But I know in my heart, that's not the right answer. Yeah.
It makes it, so the information that you're learning when you're sitting in lectures and then you go to clinicals and then they're telling you things that are different, it makes you realize the level of difficulty in all of this material that you have to know and how few people actually understand it enough to have like a blanket understanding across all respiratory therapists.
I'm just gonna say that for me, it was probably just reading too fast and just, not sitting there processing it like slow enough, because I tend to do that a lot with a lot of things and other people probably do too. Sorry, that was my phone.
All right, so they saw the CO2, they saw the vent settings. Oh, I know what to do. And then you just pick changes.
Yeah, I was probably just like overthinking or thinking too fast is my opinion for myself, at least. I'm sure there's some others that feel the same, so.
Okay, I appreciate it. Questions about auto mode. 7 people got it correct, 6 people got it incorrect. Do you get an alarm when the patient is apneic in auto mode? And the answer is no, it just switches back to full support. So every time it switches, you don't get an alarm. And then the switch goes from PRVC to volume support. And 5 people selected the switches from PRVC to pressure support. All right, and then when having asynchrony. So if a patient has auto triggering, how do you fix auto triggering? And you had a list of a bunch of things to pick. So auto triggering can come from sensitivity being set to sensitive, or there's a leak somewhere, and that leak is causing the ventilator to initiate breaths. It doesn't mention anywhere on the list for sensitivity. So the only thing you're left with is to fix the leak. There's a pressure spike at the end of inspiration for a pressure support breath. So if there's a spike in pressure, it tells you that the patient's trying to exhale and the breath is still going in. So how can we shorten inspiration in a spontaneous pressure support breath?
Shorten the eye time.
We have no set eye time.
The inspiration time, there isn't one?
No,
Oh,
not for spontaneous
I'm
breaths.
thinking PRVC. Oh, crap. Sorry.
Yeah, not for a spontaneous breath. So we could kind of force inspiration to end when we increase the percent cycle off, or inspiratory cycle off. It's our way of kind of ending inspiration a little bit sooner. If you're in PRVC and there's double triggering occurring, I'll increase the tidal volume until the double triggering stops. Don't go more than 8 mLs per kilogram. Everybody got that one correct. Very good. I'm glad everybody got that correct. I feel like I didn't cover it during lecture.
I think you did on that paper. Just out of curiosity, if they're in pressure control mode and they double trigger, does that mean they need more tidal volume also?
No, it means they need a longer inspiration.
Okay.
They'll
Just
get a
curious.
bigger tidal volume from the longer inspiration. So your answer is kind of yes.
So yeah, yes, but I know you can't set a tidal volume pressure. It's just, I was just wondering if that was, I had a guy that was doing that yesterday, so I was wondering.
In pressure control?
Yeah,
triggering?
Yeah, like it was every like 4th or 5th breath, he would do a double trigger. And then I was like, well, why? He was supposed to be in PRVC in the first place, but he was in pressure control and he had a low peak pressure. So I'm like, why don't we move him to PRVC so he can actually get more volume? Because he was only putting in like 400 mLs and he was a really big dude. So
yeah, so going to PRVC wouldn't have helped him out as much as just giving him a longer inspiratory time during that pressure control breath.
Okay.
If you have a high driving pressure, your plateau pressure minus PEEP is more than 15 centimeters water, how would you fix this? And everybody got that correct. You decrease the set tidal volume. If you have a patient having an inspiratory effort, but they're not initiating a breath, what could be the problem? Could be that your sensitivity, your inspiratory sensitivity is not set correctly, which on the new ventilators, it's almost impossible. But that's not one of the choices. One of the choices is if a patient has auto PEEP, because of all the trapped air, they're unable to generate a negative pressure or move any air into their lungs to start the breath. So the answer would be fix the auto PEEP. Of course, we fix auto PEEP by increasing the set PEEP, by giving a bronchodilator. If they're getting mandated breaths, we want to have a longer time for exhalation. Double triggering with pressure control breaths, increase the I time, it would be the correct answer.
Well, there we go.
And pressure is not building throughout inspiration in a volume mode of ventilation. In a volume mode of ventilation, we can help generate more pressure if we set a faster peak flow rate. Remember how in volume ventilation, you can set peak flow or I time, they go together. So a faster peak flow rate is the same thing as saying a shorter inspiratory time. Okay, and yeah, the extra credit, everybody got correct. So that was the advanced equipment lecture. All right, and now to go through, and any questions about graphics or anything in advanced equipment that you'd like to discuss?
No, I'm good.
There was
Thank
no
you.
new material, so I guess everything was on the test. Okay. Pulmonary function. I'm hoping I have all the reports loaded. PFT report F. Yes. For talking about the different tests, MVV, diffusion capacity, helium dilution, nitrogen washout. Should I start with a brief explanation of those before we look at the report?
Which are we on one of the PowerPoints or the paper you gave us? I'm sorry.
Yeah, so I have the PFT report up to go through it, but now I'm thinking it would be better to just discuss the different tests first and then look at the report.
Okay.
Let me just pull up the lecture really quick. All right, so going through the lecture, pardon me, when talking about maximal voluntary ventilation, MVV. We're having the patient breathe fast and deep, like 90 times a minute. So that's like not even 1 second per breath. And they're doing this for about 12 seconds. And then from the 12 seconds that they do it, we figure out what their minute ventilation would be for the full minute. So they're breathing fast. They're breathing not their vital capacity, but somewhere between their tidal volume and their vital capacity. So it's like they're panting really fast, really deep, deep as they can. And looking at this graph, that's what it's showing. So every time this goes up, they're breathing in and out, they're down, they're exhaling. So they're breathing really fast for 12 seconds. And as they're breathing, the amount of volume that they're exhaling is being added together. So every time they exhale, the volume gets added. So at the end of 12 seconds, we see that the volume is here on this picture. It shows 16 liters. And since it's 12 seconds, we multiply by 60 over 12 or 5 to find out what the minute volume would be for a full minute. And in this picture, 16 times 5 gave us 80. So the person is moving 80 liters a minute when they're doing this test. Why would somebody not be able to move a normal amount of volume in and out for 12 seconds? It comes down to them just being weak, having a neuromuscular disease, or having COPD. So all these answers you guys have. All right, now we moved on to residual volume. And in order to find residual volume, the tests that we review are helium dilution and nitrogen washout. And both of them will show what the functional residual capacity is. So the FRC. And then we have to have the patient breathe out so we can figure out their expiratory reserve volume. And then we take the FRC we got from the test, subtract the patient's expiratory reserve volume, and we know whatever is left is the residual volume. So ERV we can measure, FRC we can measure, and then we subtract the two to get the residual volume. So the first test is the helium dilution test, where the patient breathes from a container of helium until the amount of helium leaving the container kind of equilibrates and stays the same. And then we know at that point that there's the same amount of helium in the lungs as there is in this container. And the percentage in the container helps with the calculation. We don't have to know how to do the calculation. The only thing we have to know about the helium dilution test is the patient breathes at normal tidal volumes until the concentration equilibrates, and then the computer figures out what the FRC is. If the FRC is more than 120% of their predicted value, that tells us that they've got a lot more air left in their lungs at the end of exhalation, and it represents air trapping. So somebody who has emphysema, COPD, they're going to have a high FRC. And then the question is, well, what about somebody who has a restrictive lung disease? Will they have a higher than normal FRC? And the answer is no, because with a restrictive lung disease, all the volumes are smaller than normal. Not just one or two, all of the volumes are smaller than normal. So you would not have an increased FRC in somebody with a restrictive lung disease. Another thing on the testing is looking at residual volume to total lung capacity. If it's greater than 35%, it indicates air trapping. The next test is for figuring out FRC is by doing a nitrogen washout. So we know that when we breathe in air, we've got nitrogen in the air that we breathe in, and that nitrogen's throughout our lungs. If we breathe 100% oxygen, we're going to wash out all that nitrogen, and the pure oxygen will take its place. So we collect all this exhaled nitrogen, measure the amount that came out, and from that we can tell what the FRC is. Again, we don't have to do the calculation, the computer does it for us. And then we talked about diffusion capacity, DLCO. A diffusion limited gas such as carbon monoxide is used. Diffusion limited with carbon monoxide. Diffusion limitation with I told you guys the proper name during lecture, so I don't want to restate it. So this is taking in 1 breath of a small concentration of carbon monoxide. And if there's enough alveoli present, if there's good hemoglobin present, the carbon monoxide will get absorbed into the blood and attach itself to the hemoglobin. And then when the patient exhales, there won't be as much carbon monoxide exhaled. So from that, the computer can calculate how their diffusion capacity is. The test is not accurate if the person has low hemoglobin. So usually they draw a blood gas during a pulmonary function test, figure out what the hemoglobin is, and then they'll enter that value into the computer so the computer can compensate for low hemoglobin. Because otherwise it looks like they could have a normal diffusion capacity, but with no hemoglobin or low hemoglobin, it's going to show that they don't have a good diffusion capacity. So milliliters per minute per millimeter mercury. What reduces our diffusion capacity? It's kind of all the things you guys have been talking about in your pathophysiology class and anatomy class. Anytime you have something getting in the way of oxygen diffusing across the alveolar capillary membrane, like congestive heart failure, pulmonary edema, renal failure, any fluid accumulating is going to prevent oxygen from getting into the blood. If you have a fibrotic lung disease, the interstitial space thickens and that interferes with oxygen getting into the blood. And obstructive diseases interfere with the air getting down to the alveoli. So that also causes a low diffusion capacity because of the obstructed airways, just preventing oxygen from getting down to the alveoli. All right, so now the report. On this report, the maximum voluntary ventilation should have been 95.85 liters per minute. It was 55.15 liters per minute. Why would it be a lot less than predicted? In this person, they have COPD, and the obstructed airways make it difficult for the air to go in and out really fast. Here we have helium dilution, and it shows that it took 3 minutes for equilibration. And that's a normal amount of time for the helium to equilibrate. But then look at the residual volume compared to total lung capacity. We said more than 35% indicates airway obstruction and trapped air in the lungs. And that's the case with this being 42.98 or 43%. That means that there's a higher residual volume than normal. And that goes along with somebody who has air trapping. And then looking at the diffusion capacity, here it's represented as D. There's no L, so it's just diffusion of carbon monoxide to the hemoglobin. And we said 25 milliliters per minute per millimeter mercury is normal. For this person, 19.8 was normal. And their diffusion capacity is less than normal. And it's less than normal because of COPD. Or asthma.
I'm sorry. So for normal, it should be 25, right? Or are we going by their predicted, which is the 19.82?
We'll go by their predicted.
Okay, that's what I want to know. Thank you.
Here we have a maximum voluntary ventilation of 34 liters per minute. Should have been 135 liters per minute. Why so low? How come this person can't move air in and out? FEV1 over FVC is 27%. So we have obstructed airways, and that's why the MVV is so low. Looking at residual volume compared to total lung capacity. We said 35% and less is normal. This person has almost 61%. 61%, that's a lot of trapped air. Oh my word. And their helium equilibration time, it took longer, again, because of obstructed airways. And when we look at the residual volume compared to total lung capacity, it's much higher than normal. So it all fits the picture of somebody who has COPD, obstructed airways, and air trapping. And check out the flow volume loop, how it's really concave. There's almost no air flowing out of those lungs. Did we look at the diffusion capacity? I feel like I skipped it.
No, you skipped it. No.
Oh, okay. So a low diffusion capacity. Should have been 27 milliliters per minute per millimeter mercury, and it was only 18 milliliters per minute per millimeter mercury. So this person probably gets short of breath a lot. They probably desaturate with exercise and have a hard time going through their daily activities. And then we talked about methacholine challenge. If somebody complains of being really short of breath, like when they exercise or when they're moving around, but then the pulmonary function shows normal. So then they say, well, let's see if methacholine, inhaling methacholine can induce a bronchospasm. And if it does, then they come to the conclusion, pardon me, that the person has reactive airways or asthma. So this person started off with FEV1 over FVC showing 83.58%. That's good. So is everything normal? Well, let's see. If we give methacholine in different dosages, does it cause a bronchospasm to occur? And then can we reverse it with albuterol? So we're looking for the column that's FEV1%. It's right here. And baseline, it was 100%. And then it drops at this diluent. And then really drops at set number 5 when they gave 4 milligrams per ml. Then it caused bronchospasm. And then to reverse the bronchospasm, they gave albuterol, and then the FEV1% came back up to normal. So when you guys were in the PFT lab, did you notice how performing a force spirometry, it takes a lot out of you? This person had to do it to get the normal value, and then they had to repeat it 7 different times. And hopefully they were all good tests, so they don't have to repeat it even more. And then a 16-year-old or 13-year-old who feels short of breath with exercise had a normal spirometry. So we see the FEV 1% is 86 pre-exercise. And 5 minutes after exercising, their FEV 1% fell to 61%. So that's why they're feeling short of breath. It's inducing bronchospasm when they exercise. So they gave albuterol, and that brought the FEV 1% back up to 80%. Okay. So, any questions?
Okay, I just want to verify for the test we have next week, it's going to be the flow volume loops and the PowerPoint you just had up, correct?
Yes.
Okay. And
Yeah,
but
how
you
do you
said,
feel about flow volume loops?
I mean, if you want to run through it again, I'm game. So
Okay. For flow volume loops, just to go through the basics really quick, when you're performing the test, you take a deep breath in first, and your lungs are completely full of air, and that's the point that you start the test, is when you first blow out. So everything on top of this line is the flow as you're blowing the air out, and then the x-axis is the amount of volume that you're blowing out. So exhalation is up at the top, and after blowing for 3 to 6 seconds, or whenever you have that plateau, you take a deep breath in, and then when you do, that's when the test ends. So you're looking for the maximum flow rate or peak flow rate. So the tallest part on the flow volume loop is the peak flow rate. And when you're breathing in really fast, and that's your inspiratory flow rate. So the furthest point at the bottom would be your inspiratory flow rate. And then to look at your volumes, the further out it goes, the more volume you blew out. So that's a flow volume loop. Somewhere on here, we had to calculate something. We had to calculate flows at different points. So FEF 25, 50, and 75. All right, here's our calculation. So you'll be asked on the exam to figure out your forced expiratory flows at different volumes being exhaled. So first thing you do is multiply. So if it asks you to find the forced expiratory flow when 25% of volume has been exhaled, then you do 25% times the vital capacity. And that tells you 0.75 liters on this example. So 0.25, that's the 25% from FEF, times 3 liters. Where do we get that number from? That was our vital capacity, and we can see it on the graph. So 25% of the vital capacity is 0.75 liters. Then we take that number and come over here and we look for the point on the graph on the x-axis. That's 0.75 liters. And then we draw a straight line up. And everybody knows Yvonne can't draw a straight line up. And we see that the flow at that point in time was about 6 liters per second. So that's our answer. And then we repeat the same steps to figure out the flow rate at FEF 50 and FEF 75. So the forced expiratory flow at 50%, we would come back to this equation, but instead of 0.25, we're going to change that to 0.5 because we want to know the flow at half of the forced vital capacity. So 0.5 times the vital capacity of 3 liters gives us 1.5 liters. So we come over to the x-axis, straight line up, and see what the flow is when 50% of the air has been exhaled. The flow rate is 4 liters per second. And then you do the same thing for 75%, and then you see what the flow rate is. All right, is that good? Do you need another example of that?
I'm just confirming. So those points will correspond on the line itself then. If it doesn't, then we did it wrong. Like when you're at 4 for half of it, because the peak flow is 8. When you're at 4, which is half, it should be 1.5, right? So on the x-axis, it should be 1.5, and on the y, it should be 4. Is that too mathy? I'm sorry.
No, so you're looking at the tallest point here. You're saying the peak flow rate is 8 liters a second. Therefore, when the flow rate is 4 liters a second, we're at half of the volume. No, that's not how it works. And it's going to change depending on what the volume is. So if your forced vital capacity was 6 liters and 50% of 6 liters is 3 liters, you would go to 3 liters and go up and then over. So you have to know, you have to figure out the volume first and then look at the flow.
Okay.
You have to know what the vital capacity is because it's going to change depending on the vital capacity. It's going to change depending on a person's lungs. So if they have obstructed airways, they're not going to have 4 liters a second when 50% of their volume is exhaled. It's going to be a lot lower.
I think it's just because for this example, like this picture, the points kind of match up where the line corresponds. So that's why I was a little.
That's why you were
Sorry.
coming to that conclusion.
Yeah, but it makes sense. So yeah, I understand. Sorry.
No, I'm glad you asked. Okay, this was the fun part, right? Some of them are pretty easy to figure out. So normal, of course, you've got good flow rates. So this graph comes out pretty far and straight lines. When you have a restrictive lung disease, you have small volume, which makes your flow volume loop skinny. But there's nothing wrong with the airways. So your flow rates are going to be really good. So it's going to be tall and it's going to be skinny. When you see that, you know you're looking at a restrictive lung disease. The scooped out appearance means that you don't have much flow when those smaller airways are emptying. And that's having airway obstruction. It's going to give you that concave appearance to your flow volume loop. When a person has airway obstruction, it occurs during exhalation, but when a person breathes in, their airways open up. So even with COPD, their airways open up during inspiration and they can get their air in pretty easily. The problem is getting it back out. Here it's showing still a little reduced compared to a normal person breathing in. And then if you have an airway obstruction, so imagine what was our examples that we gave? Like a tumor in the main stem bronchus or a tumor in the trachea. Breathing out, it's difficult, it takes a while, but you get all the air out. So you just have to keep blowing for a longer period of time, you get all the air out. But it's also hard to breathe in, to get the air back in. Here we're seeing low flows when the person's trying to blow their air out, but they can breathe in really well. And this is an example of something occluding the airway during exhalation, but it's not occluding the airway when they breathe in. And because of the difference with exhalation and inspiration, it's called variable. I need to pull my notes out. I don't know if you guys have the notes in front of you for different examples of these flow volume loops. No, I'll get it.
You mean for each one of them?
Yeah.
I think, weren't you saying the small airway obstruction is like asthma and COPD?
Yes.
And then I think, I can't remember which one you said was like, could be like tumor or something in the main stem or something. I think it was one of the large airway obstructions, but I can't remember which one. Or it could be both technically, can it?
So number 5, it says tumor in the right main stem bronchus is what number 5 would look like. So number 5, you can breathe in just fine, but when you go to blow out, the airways narrow a little bit. And that's why you can't get the air out as well.
Okay, so I knew it was one of them.
Yeah, so this one, you've got a tumor in the main stem bronchus. And remember, airways open up during inspiration. That's what makes it easier to get the air in. But then it's harder to blow it out because the airways close a little bit. And then for the last one, it's extra thoracic, so outside of the thorax, which would be the larynx. And you can blow out just fine. So extra thoracic airways, it's opposite from inside the thorax. Outside the thorax, when you blow out, everything opens up. It's easy to blow out. But when you breathe in, the upper airway can collapse. And so that's like a tumor on the vocal cord or a paralyzed vocal cord. Tracheomalacia, I think it was another one we put in this category. Let's see, number 6. Yes, tracheomalacia. So that's hard to breathe in because there's an obstruction outside of the thorax. Okay. Any questions on that, or you're good to go?
No, thank you.
Okay, and then what about setting up a zone system for an asthmatic? What I do is remember that less than 50%, they need to go to the OR. No, less than 50%, they need to go to ER. And then between 50 and 80%, they may have to contact their practitioner to increase the amount of medications that they're taking. Sometimes they'll add steroids if they're between 50 and 80% of their personal best. Am I going too fast? Do I make sense?
You're not going too fast.
Okay. And then exhaled nitric oxide, we produce more nitric oxide when we're in bronchospasm or having an acute asthma attack. So some, I guess, doctors' offices measure exhaled nitric oxide, and that's how they follow the amount of inflammation occurring in the lungs with asthmatics. And we want to see 10 to 30 parts per billion as being normal. And if it's higher than that, they're still having an asthma exacerbation, and they would still require medications if the number is higher than 30 parts per billion. Any other questions? So the test on Tuesday for pulmonary function, you know, it's cumulative.
Sorry for the dumb question, if it's a
Oh.
dumb question.
No. So the tests are cumulative. So you will be shown a pulmonary function report and ask if it's restrictive or obstructive. If it is obstructive, remember, if it's less than 70%, then a bronchodilator is indicated. If the FEV1% is less than 75%, that indicates a bronchodilator needs to be given. And then after the bronchodilator, you repeat the test. So that will also be on the test, along with flow volume loops, MVV, the two tests for FRC, your nitrogen washout and helium dilution. There's a couple questions on diffusion capacity. I think you set up a green, yellow, and red zone for an asthmatic. And there might be a question on exhaled nitric oxide. And I think you should be good to go for that.
Is it another 25 question test?
Yes.
I thought so.
I hope I do as well on this exam as I did on the last one.
I hope so too. So let me just take a quick look at the questions. Yeah, you've got to look at a report. Was there a change after the bronchodilator? Oh, do you remember that? After bronchodilator is given, how do you know if there's been improvement?
Like a 20% change or something. I forgot the exact number. I know it was in the PowerPoint.
Yeah, so review that.
It was and then it was 150 ml change from the FVC and the FEV1, right? Or am I getting that wrong?
Was it 150 ml?
Or was it 200 ml?
I'm remembering 200, but all these years of teaching it, I still screw that up. Let me look.
It's probably, you're probably right, Yvonne.
Oh, I don't have it with me. Yeah, it might be a 200 ml improvement in the FEV1 or FVC or both. And 12% improvement in the FEV1. I guess the thought is if the bronchodilator is relaxing the airways, more air can come out. And if you can get out another 200 mLs, that's a good sign that the bronchodilator is helping. Diffusion capacity, we talked about. Abnormalities with decreased diffusion capacity, we talked about that. What is a normal peak flow rate? You have to know that.
What is a normal peak flow rate?
8 to 12 liters per second. And then for liters per minute, 450 liters per minute. If the units are liters per minute, it's 450. But if the units are liters per second, which it typically is on your PFT report, it's 8 liters per second to 12 liters per second. Dilution, diffusion capacity. Looking at a PFT report, another PFT report, RV to TLC, we talked about that. Asthmatic. Diffusion capacity, diffusion capacity. Somebody exercises and their PFT is worse after exercise, what does that confirm?
That they're in bronchospasm.
Yeah. Very good. We've got reactive airways, they're in bronchospasm, they have asthma. MVV questions. Okay, and then here comes to flow volume loops. Did we cover all of them? Yes. And then you have to calculate the FEF, the forced expiratory flow when 25% of volume was exhaled, 50% and 75% of exhaled volume. And that's your test.
Okie dokie.
You guys have a good rest of your day. I'll see you shortly, Rachel.
Yeah, I'll be down in a few. I gotta pack up
Thank
my
you,
stuff.
Yvonne.
You're welcome. Bye.
Bye.